Hi everyone, thank you again so much for joining us today for an exciting live webinar on exploring new biomarkers in high-frequency ultrasound and photoacoustic imaging. Our presenters today are Dr. John Eisenbrey and Maria Stanczak at Thomas Jefferson University. My name is Christina Asa, calling here from Fujifilm Visual Phonics, and I'll be the moderator for today's session. Just a couple of housekeeping notes for today. We will be making a recording of the webinar, and this will be made available to anyone who is registered. If you have any colleagues that were not able to sign on today, have no fear. We will be making this presentation available on our website. Everyone's lines are muted for the duration of the webinar, but we encourage you to please use the questions window on the right-hand side of your screen to ask any questions that might come up throughout the presentation. We will be answering questions at the end of the session. We expect the presentation to be about 45 minutes, leaving us 10 to 15 minutes for questions. It is my pleasure to introduce our two speakers for today. Dr. John Eisenbrey earned his BEng degree in mechanical engineering and BS in management at the University of Delaware. He then completed his master's and PhD degrees in biomedical engineering at Drexel University, focusing on ultrasound contrast media development. He is currently employed as a research assistant professor in the Department of Radiology Ultrasound Division at Thomas Jefferson University. His research interests focus on high-frequency ultrasound, and photoacoustic imaging, contrast-enhanced ultrasound imaging, the use of contrast agents for pressure estimation, and ultrasound-triggered drug delivery. John is currently a member of IEEE, the American Institute of Ultrasound in Medicine, the International Contrast Ultrasound Society, and the American Association for the Advancement of Science. Our second presenter today is Maria Stanczak, who was born in Philadelphia, Pennsylvania. She is a two-time alumnus from Thomas Jefferson University, earning Bachelor of Science and Master of Science degrees in Imaging Sciences with a focus on education. Maria is a seasoned sonographer who recently joined the ultrasound research team at Thomas Jefferson University, where she is also a contributing faculty member. Her research interests include ultrasound contrast agents, subharmonic imaging, high-frequency, and photoacoustic scanning. Maria is currently a member of the American Institute of Ultrasound in Medicine, the American Registry of Diagnostic Medical Sonographers, and the American Registry of Vascular Technologists. Her personal goal is to raise awareness of the benefits of ultrasound contrast agents. Now, before I pass things over to John and Maria, I'd like to hand things over to one of our product managers at Fujifilm Visual Phonics, Drew Heinmiller, who will be presenting some updates on some new developments in our technology. Over to you, Drew.
Thanks, Christina. Yes, Drew here. I just wanted to really quickly present a couple of things, exciting developments we have for the new Vivo laser system, because John and Maria will be presenting some data that was acquired not just on the ultrasound but also on the photoacoustic imaging system. I thought it would be worthwhile for those listening that we do have some updates. First of all, just to the brand new software and also a new piece of hardware. The brand new software is really focused on molecular imaging, where you're using contrast agents to really sort of get at some more molecular biology. And the sort of setup we have, and we've designed the software around, is around characterizing contrast agents, and we have a phantom that we've designed and some software associated with it, then visualizing those contrast agents in vivo once we've characterized them. And again, we've integrated an injector pump for doing bolus injections, and there's a lot of software based around visualizing and quantifying spectrally unmixed signals, so we can separate, say, blood signal from the signal from contrast agents like nanoparticles. And finally, there's a lot of tools to be able to analyze the data that's acquired for doing things like pharmacokinetics, microdistribution, and that kind of thing. This software is really thoroughly described in a webinar we did back in April. It's the Molecular Imaging for Cancer Research, Microdistribution, and Pharmacokinetics webinar we did, which really took the idea of, taking the kind of data that you might get in optical and saying, what are the limitations there and how can we overcome those limitations by using ultrasound and photoacoustics. So I'd invite you to have a look at that webinar, and we're just going to post a link to the webinar itself right now. So if you're curious, you'll have that link available. I think it's going in the chat. Finally, I just want to talk really quickly about the brain imaging with a vivo laser. I believe Maria is going to be presenting some of the data. But we have a lower frequency probe, so it's a 15 megahertz probe, which is still high frequency, obviously, but it's slightly lower than some of our other probes. With this probe, we have better sensitivity, better depth and sensitivity for photoacoustic imaging, and this is really not just the probe, but the jacket, the fiber jacket that we've designed to go over top, which you can see pictured here, where we're focusing the light a little more right on the mouse brain. So this is really ideal for doing neural applications. And if you have any questions, we'd be happy to take them at the end of the presentation. I just wanted to show you a couple of images. On the top, you can see on the left-hand side sagittal images, the right-hand side coronal images. The top image is oxygen saturation, and again, John and Maria will be presenting some of this. And the bottom image is color Doppler, so seeing blood flow. So that sort of gives you an idea of the kind of sensitivity we can get with this new probe. And then here are some applications, including stroke, cancer, like glioma imaging, and then some molecular imaging as well. That's a picture of a contrast agent in the ventricular system of the brain. I think we're going to post also a link to some data that was acquired on the vivo laser having to do with stroke imaging. It's actually been published in the journal Stroke. So we'll paste that link as well. It'll take you to PubMed, but it's actually a free article. So you can download that article and take a look. That's all I have, and I think we'll get right to our speakers here. I'm going to pass things over to John and Maria and let them take it away from here.
Great, thanks, Drew. So good afternoon, everyone, and thank you for tuning in. As mentioned, my name is John Eisenbrey, and I'm joined here by Maria Stanczak. And for the next 35 to 40 minutes or so, we're just going to be touching on some different projects that we've been working on here at Thomas Jefferson University in Philadelphia over the last 3 to 4 years that we've had the unit. So very quickly, our disclosures: we do get research support from GE Lantheus, and we do consider ourselves kind of a beta user for Visual Sonics, meaning that we get to play with some of these toys that Drew mentioned previously. In terms of background of our group, so we are based in the Department of Radiology within the Division of Ultrasound, and we kind of split our time between clinical research and preclinical research. And as part of this preclinical research, we kind of run and manage this high-frequency ultrasound and photoacoustics core facility that is a part of the Kimmel Cancer Center. So this is equipment that's available to anyone really in the university as well as within the Philadelphia area. And then we also use this equipment quite extensively within our own research as well. Because we weren't sure of kind of the makeup of our audience, we just wanted to spend maybe 2 or 3 minutes going over through the actual hardware and what this system comprises of for any of you that aren't as familiar with it. So in this core facility, we have the Vivo 2100 combined with the laser system, which is shown here. Essentially, this is comprised of a high-frequency ultrasound system shown here, an animal containment cage with physiological monitoring and these custom transducers, and then we also have the photoacoustic system, which is essentially an enclosed laser combined with these customized photoacoustic probes. And I'll talk about all of these separately in the next minute or so. So why do we use high-frequency ultrasound? Of course, it's really to get high resolution. And this is a slide that was provided by Visual Sonics, but it just really visualized the potential benefits of high-frequency ultrasound. So when we talk about clinical ultrasound, we're generally in this 3 to 15 megahertz range. We get resolutions of around 200 to 300 micron resolution. When we're going to our preclinical units, our high-frequency ultrasound, we're now 30 to 80 megahertz. Of course, this gives us limited penetration depths, which is not too big of an issue in preclinical imaging, but it does give us very high resolution, so 30 micron resolution. And then this is just a very nice example showing you how similar a micro-ultrasound of a mouse fetus looks compared to the human fetus example shown here. So very high resolution, very good ability to kind of delineate small structures. So we have a lot of packages built into this equipment. We kind of spend a lot of our time doing visualization. So this can include tissue, organ, or tumor identification, as well as the identification of vascular density or structures. Of course, in radiology, that's not really enough anymore, though, so we do spend a lot of time doing actual measurements and analysis. And these include things that are all built into the machine but relatively basic, such as measuring linear distances, areas and volumes, blood flow velocities, cardiac measurements, and also some of the quantification packages that are built into the machine for looking at contrast quantification as well. So we use these in kind of multiple different areas around different projects here. We do quite a bit of early detection and screening, which is shown here on the top left. We do a lot of visualization and quantification of vascularity, both in 2D and 3D, using power color Doppler, which is shown here. We do quite a bit of work looking at actual blood flow kinetics and perfusion, so the equipment is allows us to do quantification of ultrasound contrast agent kinetics. And then we also do quite a bit of volumetric scanning, because it's been pretty well documented that this is a much more reliable method for tracking tumor progressions in particular than traditional 2D imaging. As I mentioned, our unit is also equipped with this photoacoustic imaging technique. So this is an emerging technology, and essentially involves these transducers that have not only the traditional ultrasound elements, but also they're attached to a fiber optic cable which can deliver light to a region of interest. So the ROI experiences a thermoelastic expansion which generates a pressure or sound wave, and then this sound wave at any particular at your desired particle of interest generates this sound wave, and that can be detected by the ultrasound elements. And a way we generally describe this to our students is it's very similar to lightning and thunder, where you have this discharge of energy from the lightning, you then wait a few seconds and you hear the thunder from that pressure wave that's created. And what's also nice about this system is it also has very good perfect co-registration of your anatomical ultrasound data of your grayscale or your B mode with the actual physiological photoacoustic data. So not only are you able to get this molecular or physiological information from the photoacoustics, but you're also able to tell exactly where in the animal you're looking at as well. So we've used this for a variety of different applications, but probably 90% of what we do in our group is looking at oxygenation measurements. And this is all software that's built into the system, and essentially it relies on the fact that the absorption spectra of hemoglobin shifts dramatically depending on whether or not that molecule is oxygenated or deoxygenated, which you can see here. So essentially by firing at multiple wavelengths and looking at the ratios between the two, we're able to compute the percent oxygenation of the blood that we're looking at or the tissue that we're looking at, and we can also look at total hemoglobin as well. So in terms of a brief overview of what we'll be talking about for the next 30 minutes or so, I wanted to give kind of a brief hodgepodge of examples of things that we've scanned over the last 3 to 4 years, just to get your imagination working and see different applications that we've used the machine for. Following that, Maria will talk about in much more detail 2 ongoing projects using high-frequency ultrasound and photoacoustics. And then finally, we'd like to share just some of our tips and tricks for scanning, because it's nice to see what other groups are working on, but it's also nice to come away with a few other things to improve what you're doing on your end as well. So with that in mind, we spend quite a bit of our time doing tumor monitoring, either in 2D or 3D. This is just one example of a collaboration with a group in the Cancer Center where we are tracking the progression of a prostate tumor model over between groups with different therapies. And here you can see we're looking at the mouse prostate and then the general progression or lack of progression in some cases of these prostate tumors. And you can see that with using this technology, we're able to visualize these quite nicely. We're able to quantify volumes in 2 dimensions quite nicely. And without imaging, these would be groups of animals, large groups of animals that would have to be sacrificed at each individual time point. So it's a way to quickly monitor your tumor progression. The field of cancer, I think, at least in my opinion, seems to be progressing more towards orthotopic models, in which case imaging is even more important. And for a lot of the work that we've done, we've begun using 3D tumor monitoring, which I'm showing you here an example. So this is an example of an HCC that's been implanted in the liver of a nude rat. And essentially what we're just doing is we're doing 3D volumetric tracking of these tumors, comparing various treatment groups. You can see that we're able to delineate nice changes in tumor progression between these groups and get very fine, high-resolution, detailed estimates of the overall tumor volume. As I mentioned, we do quite a bit of photoacoustics as well. So this is just one example of a photoacoustic project that we are running about 2 years ago or so. This is a collaboration with a group in orthopedic surgery, and they're interested in the use of non-thermal plasma for wound healing. So they have this very nice model where they punch a hole in the ear of a mouse, and then they either apply plasma or they don't, and they look at how quickly this hole within the ear actually closes. And they've gone ahead and they've identified that this plasma is very effective. It aids in the process of wound healing, but they were really interested in what's going on kind of the more molecular level. So with that in mind, we used power Doppler and photoacoustic imaging to kind of track the oxygenation and vascularity in these mouse ears over time. And what we were able to show is we get this very nice significant jump between the plasma treated and the control groups at day 4 in both overall hemoglobin or vascularity as well as oxygenation at day 4. And this enabled them to kind of focus some of their histology experiments more on that time point and confirm what's going on with some of the plasma behavior there. Another project that we've been actively involved in is this development of an animal model for onchocerciasis or river blindness. So this is a neglected tropical disease as designated by the WHO. Essentially it results in subdermal skin nodules, itchy skin rashes, and eventually blindness. It affects quite a lot of people, 26 million people afflicted, 1 million will eventually suffer blindness. But really the issue with this, particularly for coming up with drugs and different therapies, is there's no existing animal model for this disease. So a lot of the research is done in human volunteers who already have who have this onchocerciasis infection. So with that in mind, this group that we've been working with in microbiology has gotten funding from the Gates Foundation to essentially try and develop a animal model for onchocerciasis for improving drug screening. So they've developed a humanized mouse, which they've now shown that these worms can live up to, I think, 4 months or so in. The issue is that the mice are very, very expensive, so it's, humanization is quite a detailed process. So sacrificing the mice and doing dissections looking for worms is really prohibitive in a lot of cases. So with that in mind, we've applied high-frequency ultrasound to track not only implantation but also the progression of these worms over time. And here I'll show you 2 examples. I know this is going to run a little slow probably on your PCs, but here I'm showing an example of the needle being injected IP into the mouse. There's a little bit of motion here from some of the worms that are there, but then once we remove the needle, we're able to visualize this high motility pattern within the IP space and visualize these worms. And what's nice is that we can continually scan these mice every week or so. This is an example 6 weeks post-injection. So we're now looking at depths of 0.2 to 6 millimeters down, still in the IP space just above the kidney. But what we're able to see and track with ultrasound is the growth of these worms over time. So now they're up to 6 millimeters in length or so. You can see that this particular worm is kind of attached and it's kind of flapping with the motion of the animal as well. So a nice way to confirm that there are in fact living worms still in these animals. We also confirm this ex vivo as well, but a way to save some pretty valuable and expensive mice. Finally, the last quick example I'll show you before I pass it on to Maria is people always ask us what's the smallest thing you can see. Well, the smallest thing that we've scanned to date are fruit fly larvae in adults. And this was done in collaboration with a group in cardiology where they are looking at different genetic knockouts in these fruit flies. And prior to applying any type of imaging, they would essentially apply these knockouts to different groups and just measure how long the animals live, how long the flies live, which works, but there's certainly a lot of confounding factors in there. So we were interested in, can we use high-frequency ultrasound, in particular Doppler imaging, to actually quantify and measure changes in cardiac function within these different groups. And before I show you examples, I think it's worth noting, because we certainly didn't know this prior to imaging, that the vascular structure of fruit flies is quite different from ours. So they really just have a single tube that runs from the head to the tail, with several of these kind of muscular heart-like structures that pump blood from the head to the tail. And what we were able to show with this group is that we can in fact detect Doppler flow within this aortic-like structure going from the head to the tail in both 2D and 3D power Doppler imaging. And we've also been able to quantify not only aortic-like velocities but also heart rates as well, and compare these between groups as well. So a very interesting application for something that's not really applied in the field of ultrasound. So on that note, I'll now pass it along to Maria, who will be talking in much more detail about 2 of our ongoing projects that use both high-frequency ultrasound and photoacoustic imaging.
Hi, good afternoon, everybody. Thank you for joining in, and I'm just going to share with you some of, as John said, the ongoing projects that we are currently conducting. One project that we've been working extensively on is an animal model of intracerebral hemorrhage. Intracerebral hemorrhages in general account for about 10 to 15% of all strokes. However, they are associated with a higher morbidity and mortality rate. Unfortunately, currently there is inadequate evidence to support any one treatment process that's effective, and unfortunately therapeutics are near non-existent. That being said, there's definitely a lack of suitable animal models, so our collaborative group set out to develop an animal model of intracranial hemorrhage using Swiss Webster mice. Each of these mice underwent right intracranial hemorrhages through direct cerebral injections of a collagenous material. We preserved the left hemispheres for controls. Our images consisted of 2D and 3D grayscale, photoacoustic, color, and power Doppler, which we obtained 24 hours post-induction, 48 hours and greater than 1 week. Initially, our biggest hurdle was just optimizing our acoustic window. So the images that you're seeing here, the grayscale images, just outline the process involved. The image on the far left was taken through the a scraped right skull, and you can see that the intracranial contents were not well visualized. But we did improve through a thinned right skull and then ultimately optimizing our acoustic window through right partial craniotomy, which you see on the grayscale image on the bottom right. Interestingly enough, it only required a small portion of the right skull to be removed in order to see both hemispheres nicely. We assessed our ability to see in our acoustic window just based on the visualization of anatomic landmarks. So we wanted to be able to see the temporal parietal lobe, which you can see right here, the corpus callosum, and then ultimately the thalmi. In terms of vascularity, we wanted to be able to see the anterior choroidal arteries as well as their tributaries, and we were hoping also to see, which we were successful in seeing, the internal carotid artery junction. We did collect saturated oxygen levels at each time point, and these images that you're seeing on the bottom, both grayscale and photoacoustic, just outline the process involved in regards to analysis. So we draw ROIs on the grayscale side and then duplicate that on the photoacoustic side, and we average the amount of oxygen levels over about 50 frames. So results, we definitely saw changes in echogenicity and heterogeneity at each time point, and the B-mode images that you're seeing, the one on the far left was taken 24 hours after injection. You see that the hemorrhagic area itself appears pretty much uniformly hyperechoic. 48 hours post-injection, the hemorrhage appears a little bit chaotic with areas of increase and decrease echogenicity. And then, of course, greater than 1 week post-injection, not only does the hemorrhagic area appear much smaller, it looks predominantly hypoechoic. In terms of size, the largest hemorrhages volumes were obtained 24 hours post-injury, with the smallest volumes calculated greater than 1 week post-induction. The image on the bottom right is a grayscale 3D rendered sagittal image, which was acquired 24 hours post-induction. You see the hemorrhagic area nicely outlined. And essentially what we do is we take our 3D volume with the animal under anesthesia. It takes just a few seconds, and then I go back to my PC and work on the volumetric quantification. This way it minimizes the amount of time that the animal is actually under anesthesia. In terms of vascularity, we definitely observe perfusion pattern changes at each time interval, and the color Doppler images that you're seeing, the one on the far left was taken 24 hours post-injection. We saw an increase in vascular perfusion on the control side, which you see here, with a decrease in vascular perfusion seen on the affected or hemorrhagic side. 48 hours post-injection, the control side continued to demonstrate an increase in vascular perfusion, as well as the hemorrhagic side still looked like diminished flow, although we did see a little bit more than we did 24 hours post-injection. And then, interestingly enough, greater than 1 week post-injection, we saw almost a near return to normal symmetrical patterns bilaterally. In terms of oxygen, we calculated a decrease in oxygen levels at 24 hours with subsequent increases bilaterally recorded 48 hours and greater than 1 week. The image on the bottom right is actually looking at the cranium from the top down. We see the control side here as well as the affected hemorrhagic side. This is a calculated oxygen saturation map which is acquired 24 hours post-injury, and you can clearly see the differences in the amount of oxygenated and deoxygenated hemoglobin between the two hemispheres. So in conclusion, high-frequency ultrasound and photoacoustic imaging were supportive adjuncts and continue to be supportive adjuncts for the evaluation of intracranial hemorrhage at 24, 48, and greater than 1 week post-injection. And currently, we are using this tool as a non-invasive way to monitor the efficacy of thrombolytic therapies. So that brings us to our next topic, which is the monitoring of skin graft oxygenation levels following placement and over the course of therapy. So just some brief background information as to exactly what fasciocutaneous flaps are. Essentially, they're transfers of skin designed to cover large superficial defects. In this particular flap, they rely on the small neovessels within the fascial plane for their blood supply. That being said, vascular compromise is the most common cause of failure. Clinically, post-op monitoring is necessary to identify early signs of failure, which at this point include looking for areas of discolorization, as well as poor venous return. And our collaborative group here at Jefferson are actively researching risk factors for graft rejection, such as age, alcoholism, and obesity, which tend to, in those populations, which tends to lead to greater flap failure. So this project, we used 23 Sprague-Dawley rats. Each rat received bilateral anterior abdominal wall flaps, which you can see on the bottom right image. Intentionally, the left superficial epigastric artery was clipped, which was intended to develop ischemia throughout the entire flap. We kept the right flap as controls, and changes in saturated oxygen levels were investigated, and we quantified those changes or conducted those image acquisitions at baseline preoperatively, and then 24 and 48 hours post-operatively. So results of the B-mode imaging, all flaps appeared as hyperechoic structures that we see here. They ranged in thickness between 1.7 and 2.3 millimeters. Below that is the muscle layer, and then of course the peritoneal lining, and we were able to see in peritoneal movements. In terms of baseline photoacoustic imaging, bilateral baseline saturated oxygen levels were variable. I should say that initial image acquisitions, we actually calculated oxygen levels at each segment of the flap, and at that time we determined that the earliest changes were seen in the mid and distal flap. So therefore, moving forward, we placed our probe kind of halfway between the mid and distal flaps to not only give us a good gradient, but also to see the changes in those particular segments. 24-hour follow-up imaging, we calculated an increase in saturated oxygen levels within the control flaps, and you can see the photoacoustic images on the bottom. The image on the far left was the control flap. And then 24 hours following surgery, the compromised flap demonstrated decreased oxygen levels, which we see here on the bottom right. 48 hours follow-up imaging, the control flap continued to demonstrate increased saturated oxygen levels, and the compromised flap continued to demonstrate decreased oxygen levels. And the images, the top images on the right here demonstrate mid and distal flap segments acquired at baseline, which is this top image that you're seeing, and then 48 hours post-operatively. So you can clearly see the changes that just a day or two make. And then in some cases, variations in oxygenation were observed between segments, resulting in eventual segment necrosis. This really nice image on the bottom, this photoacoustic image here, was taken 48 hours post-operatively, and you can see a nice gradient between the mid-segment, which is predominantly red, and the distal segment. And interestingly enough, necrosis was observed in this flap about 4 days post-operatively, which tells you that the photoacoustic information determined early signs of at least partial failure, if not full failure, a whole 2 days, 2 days before any kind of visual inspection. In terms of flap outcomes, a total of 45 flaps were analyzed. Biopsy confirmed 62% had complete flap survival, while about 39% demonstrated partial flap failure. And what we're seeing on the bottom, these photographs were taken 7 days post-operatively. So the image on the far left, or photo on the far left, demonstrates a completely surviving flap with its corresponding photoacoustic image, which was acquired 24 hours after surgery. In the middle was a partial flap failure. You can see signs of early necrosis in the distal flap, with, again, the corresponding photoacoustic image that you see that was acquired 24 hours. So you start to see changes occurring. And then the image on the far, on the bottom on the far right was a completely failed flap. You can see extensive areas of necrosis. And then interestingly enough, the photoacoustic image, which was taken 24 hours post-operatively, you can see that quite a decrease in saturated oxygen at that time. So correlations with photoacoustic changes, I think the most important thing is you can see that the baseline levels between both right control flap and compromised flap started out more or less equal, but over time the middle and distal flap started to show changes. The flap, of course, the surviving flap is this kind of lighter shade of blue, and the failed flaps are this darker blue here, but you can see decreases in saturated oxygen levels in the failed flaps. And the correlations again with photoacoustic changes, overall there was sensitivity of about 87% and specificity of 91% in determining flap fate. So in conclusion, assessment of fasciocutaneous flaps in Sprague-Dawley rats can be achieved. Measuring changes in saturated oxygen levels seem to be a useful tool, and our current work is now focusing on correlations with pathological markers as well as graft models and risk factors. So the last thing John and I would like to talk about are just tips and tricks for improving scanning, and the bottom line is we hope that you learn from our mistakes and we can provide you some useful insight into acquiring good data and good images. So the first, contact. So improper probe contact will minimize your photoacoustic signal. So kind of what I've adopted as my normal practice, which is I do a quick freehand scan with the conventional transducers. It gives me an idea of exactly the angle or how I want to angle not only the stage but perhaps the photoacoustic probe. The image that you're seeing on the right is actually one of our mice that has the intracranial hemorrhage. You see the suture is minimizing our photoacoustic transmission. So just from angling the probe and or animal, I'm able to maximize the photoacoustic transmission and optimize our image acquisition. And then the last bullet point here is linear footprint round structure. What do you do? I can't stress enough that you want to mobilize the part as best as you can. In terms of cranial imaging, you want to at least tape the ears down if possible. And then also too, I kind of immobilize the head between my two fingers and then slightly lower the photoacoustic probe before aligning. Next, it's all about the depth. So ideally, your region of interest should be placed at depths between 8 to 10 millimeters. And don't be scared to use a generous gel bath if you need to create more depth. So when possible, flatten the surface to ensure equal distribution of the signal. The image that you're seeing on the right is of an anterior abdominal wall. You see that there's a slight elevation that's just beyond what the best depth should be, which is at 8 to 10 millimeters. So just by flattening the abdominal wall a little bit, we've now created a symmetric symmetrical distribution of the photoacoustic signal, and ultimately this is going to make a difference in calculating the amounts of oxygen. So that being said, I'm going to pass it over to John, who's going to finish up. I want to thank you today, for joining in with us today.
Thanks, Maria. So my tips that I like to share, the first being that time matters. So we spend quite a bit of our time doing clinical research, in which case we'll maybe have 1 or 2 patients in a day. And that varies dramatically when we start to get into preclinical imaging, when some days we'll have 20 to 30 animals. Also, it's important to keep in mind that the preclinical protocols often involve a lot of multimodality imaging. So we can be doing grayscale, Doppler, contrast ultrasound, and photoacoustics, all in a single animal, and it's important to really just be cognizant of the time. And most important, it's also important to remember that your patient, in this case, your animal, is often compromised, particularly in the hemorrhage animals that we showed earlier, and they're under anesthesia. So it's very important to just keep an eye on time and really to be efficient while you're scanning. So tips to kind of achieve this that we recommend is save all of your images and then delete things later. Originally we were in the habit of kind of assuming that we could get a better window somewhere else. We wouldn't save the image we had, and then we would have to go back and collect it again. So it's much easier just to save everything and then go back and delete it. The second tip is really to use those presets. So the unit has built-in TGC presets as well as imaging parameters. This not only saves time, but it also keeps things much more consistent when you're doing these longitudinal studies. It's a very useful and powerful tool. The third tip is to prep the animal in advance of scanning, and this is something when we're working with other groups that we really stress with them. There's no reason to have your animal on the table under anesthesia while you're shaving it or narrowing it and waiting for the nair to take place. So we really insist that any animal that comes in that's going to be scanned should already be prepped in terms of hair and the area be ready for imaging. The fourth one, which is easier said than done, is to really just settle for good to great, but not always perfect. I know as a sonographer, as a researcher, you're always thinking that you can potentially get a better image somewhere, but it's important to make sure that the animal does okay, gets off the table and survives, and still get a decent image. And really, in order to do this, we stress that you watch these physiological data that's being displayed in real time on the machine. And based off of experience with different animal models, we set individual time limits as well in different models, saying when that 20 to 30-minute time window is up, the animal comes off the anesthesia, because you really don't want to kill a very expensive mouse, particularly when it's somebody else's very expensive mouse. The second tip that I'll share is that we have found with photoacoustic imaging that the gel matters. So traditionally, when we were just doing ultrasound, we would kind of acquire most of our gels from either expired or discarded gels from the clinical area, and this really consists of a high variety of different gels. And this is some work down at the bottom right that I'm showing that one of our students, Caitlin Finley, looked at, where she looked at just photoacoustic signal intensity from a methylene blue gel. The only difference being the type of acoustic coupling gel that was used. So we used blue gel, clear gel, high viscosity gel, and this white ultrasound lotion, which I don't think is made anymore. But as you can see, that it, the color within the gel does in fact affect the intensity of your absorption peaks. So it's important to keep this consistent. Additionally, within the gels, it's important to have bubble-free gel for photoacoustic imaging. You can do this by either centrifuging your gel or purchasing it. And one product that I highly recommend, we don't have any stock in it or anything, these are these disposable single-use gel packets. We can usually get 3 to 4 animals from every packet, but they are, they're not fully sterile, but they're cleaner than our normal gel bottles. They are certified to be bubble-free, and probably most importantly, they're also a higher viscosity. So for those of you who have done photoacoustic imaging in the past, you know that your probe is actually, it's almost always inverted, even prior to making contact with the animal. So having a nice, relatively thick gel that will stick to that surface and stay there, as you can see I'm showing you here on the bottom right, comes in very handy, and you don't have gel kind of sloughing off onto the animal all over the place. Finally, the last tip that I'll share is that it's always helpful when you're starting a new project to really start in vitro if you can. So for new applications and imaging properties, it's nice to kind of know what you're looking for before you go in vivo. This can include echogenicity, motility, absorbance peaks if you're looking at photoacoustics. These are things that can all be confirmed in vitro prior to going to the animal. So my tips would be to design an appropriate phantom for testing. So in the case of the onchocerciasis worms, we looked at water bath just to confirm the motility and the echogenicity. For some of the photoacoustic parameters, we've looked at agar gel or polyethylene tubing in water. And in particular for photoacoustic imaging, you can actually save these absorption spectra that you take in vitro and then use the built-in spectral and mixing packages and actually subtract all the other photoacoustic signal so you're able to really confirm that what you're looking at in vivo matches the absorption spectra that you saw in vivo. And there's some nice webinars on Visual Sonic's website for this if you're interested in more. So on that note, I'd just like to thank all of our collaborators, particularly Fleming, Forsberg, and Jimmy Liu in radiology. As I mentioned, we work with several different groups in this particular presentation: microbiology, ENT, and emergency medicine. Support in terms of expertise and knowledge from Visual Sonics, Lantheus Medical Imaging, and GE Healthcare, and then all of our funding sources. And on that note, I'd just like to thank all of you again for tuning in to us here in Philadelphia and answer any questions. Thank you.
Great. Thank you so much, John and Maria, for that really exciting presentation with all those very interesting results, especially that fruit fly imaging I thought was extremely compelling. We do have a couple questions that have come in, but I encourage everyone else out there to please use the question window in the panel on the right-hand side of your screen to ask any questions that may have come up throughout John and Maria's presentation. We also have Drew Heinmiller still here if you have any questions about, more product-related questions about the things he presented. Okay, so as some more questions are trickling in, I'll ask a few that have come in. Maria, can you describe a little bit more the skull thinning technique that you used in that first study that you presented?
Hi, I'm sorry about that. We just had to switch headsets for a second. So it's just a Dremel drill that shaves down the cranium.
Okay, thanks a lot.
Oh, they make an I'm sorry. I should say they open up the skin and they kind of pull a flap over and then drill right on top of the skull, and then they suture the skin back up.
And how far do you grind down the skull? To what thickness?
Well, the actual scraping and thinning didn't really optimize the acoustic window. I'm not sure exactly what what the intentions would be, but we definitely had trouble seeing vascularity through the scraped and thinned right skull. So I suppose it depends on what application they would be using it for,
okay,
and the age of the animal.
So the next question is concerning the fasciocutaneous flap, the project you presented on that. Can you allude to why Sprague Dawley rats were chosen as the animal model for this case?
Yeah. So Jefferson does quite a bit of research into alcohol-related injuries. So we have here a colony of essentially pair-bred Sprague Dawley rats, where each individual rat has a brother that has had the same number of calories for its entire life, just with or with alcohol. So that the Sprague Dawleys were picked for that particular reason, because we're translating now into that alcohol model.
Okay, great. And a more translational question about that same flap project: how is flap failure currently being assessed in the clinic?
So it seems as though they look for areas of discolorization as well as they look for venous pooling or venous return. So they're the two main ones. At this point, I did find one article that actually has acquired oxygen levels, but that was in a research setting. But at this point, the physician just writes orders for the nurse to just keep monitoring the actual flap. That's it.
Okay, that's interesting.
Yeah.
So a final question we have here is for the FLAP project, while you were doing your photoacoustic scanning, did you consider doing a 3D scan as opposed to just that sagittal section?
Yes, we did. The 3D scanning takes a little bit longer, and we didn't at this point in this project. It didn't really give us much benefit.
Okay, great. Thanks, Maria.
I wanted to say, Christina, if I could just add in regards to clinical flaps, is that early intervention is the only way to possibly salvage the flap, that once the flap actually starts to show signs of necrosis, quite likely the flaps have to be removed completely.
Okay, yeah, that's really interesting. It's a nice translational piece to that project. Okay, so it looks like that's all the questions we have for today. So I'd like to thank everyone very much for connecting with us, and we encourage you to please continue connecting with us at Fujifilm Visual Sonics by either going on our website, our clinical site, www.vivomd.com, or www.visualsonics.com for our preclinical site. You can submit any questions or support requests via web forms on our website. Please keep in touch with us and keep track of our webinar series, and the URL for that is below. You can find us on all your regular social media channels. You can also visit us at our booth at various conferences, and the list of conferences and events we attend is also listed on our website. If you have any questions about the product or technologies used in today's webinar, please contact our product manager, Drew Heinmiller, and he would be very happy to answer any questions you might have. So once again, a big thank you to Maria and John for all their hard work and their excellent and very engaging presentation, and thank you all for joining us. Have a nice day.